Good evening, everyone. And in coming 45 minutes, we will understand about this new molecule that is Dacomitinib, which is a EGFR inhibitor for non-small cell lung cancer. So, if you look into lung cancer, we have non-small cell lung cancer and small cell lung cancer. And if you come into non-small cell lung cancer, histologically, we have adenocarcinoma and squamous cell carcinoma. So, if you look into the whole adenocarcinoma subgroup, we classify adenocarcinoma into different subgroups based on the type of mutation they have. So, you can see in the below pie chart where we have two pie charts, you can see the variety of mutations we have in Asian and in the Western population. You can see the big light green, even one half of the pie is basically EGFR mutation. So that is the reason why in Asian population this EGFR mutation becomes very significant. So we basically classify. So lung cancer is now not a single disease. Non-small cell lung cancer constitutes majority, around 80% is non-small cell lung cancer. In that, we have the most common is adenocarcinoma, and these adenocarcinoma has not got correlation with smoking history. And if you look into adenocarcinoma as such, the it is again not a single disease. The disease is different in that each type of adenocarcinoma is mediated by different driver mutations. So you can see that nearly 50% of them adenocarcinoma in Asian population is due to EGFR mutation, and you can see the rest other mutations including ALK, ROS, MET, RET, BRAF, HER2. So these are the ones that we see. So if you look into the Western population, you can see a whole chunk of uh, population where you have RAS mutation being there. This is basically RAS mutation will help in excluding the presence of other mutations. And then you can see the EGFR, the number is so small, it is just around 15% if you look into the Western population, whereas in Asian population it is 50%. And then we have the ALK mutation, RET mutation, HER2, BRAF. So these are the ones. And you can see the 50% in Western population basically have no driver mutations. So in those patients who have no driver mutations, in them we do a PDL1 and look for immunotherapy. So to just summarize this slide, so lung cancer has non-small cell and small cell, and in the non-small cell we have adeno and squamous. And if you look into adeno, which is the most common, it is a heterogeneous disease with different driver mutations. And if you look into the EGFR mutation, this constitutes nearly 50% of the non-small cell lung cancer and is the most common driver mutation present in Asian population. So this is what is in Asian population most common mutation. So this is again the lung cancer incidence as we see the men and women. You can see as many women as men as the time progresses, and it has high mortality because lung is a vital organ. You cannot get away with lung cancer and has high conversion to mortality. And this is the EGFR gene. This is the structure of EGFR gene. You can see the EGFR family of receptors that we have. You can see the ERBB1, ERBB2 is basically the HER2 new, and then the ERBB3, and then the ERBB4. So these are the epidermal growth factor receptors, and we basically classify the tyrosine kinase inhibitors into three types: first generation, second generation, and third generation. So we have anti-EGFR blockers, which or anti-HER2, like we have trastuzumab, pertuzumab. They bind to the extracellular domain, and we have anti-EGFR like cetuximab that bind to the extracellular domain over here. Whereas we have the tyrosine kinase inhibitors, which are small molecule tyrosine kinase inhibitor. They inhibit the intracellular pathway of near the tyrosine kinase domain. So, if you look into the three generation of TKIs, the first, second, and third generation. The first generation we have gefitinib and erlotinib. Second generation we had afatinib, and now we have dacomitinib. And third generation we have osimertinib. The first generation TKIs basically are reversible inhibitors of exon 21 and exon 19, and they also have some sort of activity on wild type EGFR. Therefore, they have modest efficacy with some amount of side effects. Whereas if you look into the second generation TKIs, they are pan HER2 or pan ERBB blockers, where they are more efficacious, and again they have a higher toxicity profile, especially diarrhea is what we see, and mucositis. Then if you look into the third generation TKIs, which is osimertinib, it binds to exon 19 and 21 and has least activity on the wild type, and also specifically osimertinib has activity on the T790M. Then going further, so you can see, this is what I was saying, you can see dacomitinib is sort of a irreversible inhibitor, and it is a pan HER2 or a pan ERBB inhibitor. So if I inhibit only one receptor, then of course the efficacy is there. But if it is irreversible and a pan or a blanket inhibitor, there of course the efficacy is better, but also has a higher toxicity profile in terms of more diarrhea. So dacomitinib and afatinib are basically second generation TKIs, which are irreversible pan ERBB inhibitors. They have a better efficacy if you look into the preclinical data also. They have a better affinity because of irreversible blockade, profound blockade, and they also have activity on wild type EGFR. Hence, they also have a greater toxicity. So you can see the below diagram where the the all the types of HER2 are inhibited. And if you look into the IC50, the inhibitory concentration inhibiting 50% of, you can see the least IC50 is for EGFR, nearly 6, and then we have the HER2 blockade, and then we have the HER4 blockade, and there is no HER3 activity. So if you want to get a anti-HER2 activity, you need to give a larger dose, whereas with with the least concentration, it is effective on the EGFR. And then this is the trial which we are going to speak today. This is the registration trial where there was we have clinical trials of gefitinib, where gefitinib was compared with chemotherapy, and then we have trials of erlotinib. Again, the comparator arm was chemotherapy, and then we have the afatinib, which came up again. The comparator was chemotherapy, and then we have now dacomitinib, where the head-to-head comparison is with TKI, and of course we have osimertinib. Again, the comparator arm is head-to-head with the TKI. So this is a trial where you have a head-to-head comparison of a second-generation irreversible HER2 blocker or pan ERBB blocker, that is dacomitinib, versus gefitinib, which is a first-generation reversible EGFR blocker, and this is a phase 3 randomized trial. And you can look into the phase 2 study, which was named as Archer 1017. It was basically a phase 2 study where dacomitinib was used as monotherapy in selected patients with adenocarcinoma. So in Archer 1017 trial, there were higher response rates in patients with exon 19 and exon 21, and there were low response rates in HER2 mutant or HER2 amplified, because the IC50 required for HER2 amplified and mutant is quite high, and therefore there were lower response rates. And then we have the Archer 1050, which is basically a phase 3 randomized controlled trial where it is dacomitinib 45 milligram once a day versus gefitinib 250 milligram once a day. And this is the study design we have. It's a phase 3 randomized open label study to evaluate Dacomitinib as the alternative first-line treatment of patients with advanced NSCLC. You can see the key eligibility criteria. They should have had some sort of an activating EGFR mutation. They should have had measurable disease, no prior systemic therapy for advanced NSCLC, and they had excluded CNS disease or CNS metastasis, and no prior TKI, and didn't include a ECOG performance status of 0 to 1. It was a 1:1 randomization of 450 patients, and you can see Dacomitinib versus Geftinib, 45 milligram once a day versus 250 OD. The primary endpoint was progression-free survival. One was by the investigator and the other was by the blinded independent response committee. So the secondary endpoints were the PFS, overall response rate, duration of response rate, time to treatment failure, overall survival, and overall survival at 30 months, and safety and patient-related outcomes. So the stratification was done based on the Asian versus non-Asian, EGFR mutation type, exon 19 or 21. So you can see the baseline characteristics of the two groups. It was fairly well balanced. So what we need to look into is we had nearly 75% of them were Asians. You can see 75% Asian population we had. Then you can see the ex-smokers or reformed smokers were nearly 30%, and you can see 60% exon 19 and 40% exon 21. So this is the progression-free survival by the independent committee review. You can see a statistically significant improvement in progression-free survival. So with a p-value of less than 0.0001 with a hazard ratio of 0.59. And you can see the PFS of 14.7 months versus 9.2 months with Geftinib alone. So there was so if you put on Dacomitinib, you have on an average, a patient can be on the same tablet for nearly 14 months and it is crossing 1 year. So if you look into the investigator assessment, then the progression-free survival is nearly 16 months versus 11 months, again with a statistical significance with a significant p-value. And you can see the subgroup. So Asians constituted a larger chunk, and that's the reason probably why the confidence intervals are small and statistically significant. So Asians did show a greater benefit when compared to non-Asian population, maybe because of numbers. Then this is the response rates which we have. You can see an objective response rate of 75 versus 72%, not statistically significant, and you can see the p-value in median duration of treatment 14.8 versus 8.3 months. And the OS was not mature with only 36.9% of events at the time of data cutoff. So we have a better overall response, and this is the waterfall plot showing you can see a big chunk and more deeper responses with Dacomitinib when compared to Geftinib. And this is the toxicity profile. So as I said you in the initial part, Dacomitinib is an irreversible inhibitor of ERBB, and therefore you will expect greater side effects, and also it has a pan ERBB activity. You can see the amount of diarrhea. Grade 1 to 2 is nearly 78% and grade 3 is 8% when compared to 55 versus 1%. So quite significant diarrhea. Again, stomatitis 40% and 4% versus 17 and 1 less than 1%. And this is the two main important things which we note. And then we have dry skin, and then we have transaminitis. So this looks to be a little more toxic drug than even the grade 3 toxicities are quite significant. However, the grade 4 toxicities are not much different except diarrhea in one case. So otherwise, this looks to be a safe drug, except that a little bit of diarrhea is more. Also, the efficacy is more proportionately. You can see the serious adverse events. The total 27% versus 10%, and in the 27 and In Geftinib, it is 22%. So the cause of death related to treatment, Dacomitinib 2. So one related to untreated diarrhea, one related to untreated cholelithiasis and liver disease. And Geftinib was mainly due to diverticulitis, a rupture complicated by pneumonia. So if there is diarrhea, we can go by one dose reduction if we are not able to control with conservative measures. So the first dose reduction is 30 milligrams per day. The second dose reduction is 15 milligram per day. And Geftinib becomes every alternate day or every 2 days. So if you look into the median time to first dose reduction is 2.8 months versus 3.3 months in Geftinib, and duration of dose reduction is 11.3, and the reduction to 30 milligram is nearly 38%, reduction to 15 milligram is 28%, and nearly total number of patients with some dose modification was nearly 66% in Dacomitinib arm. So this just reflects the amount of toxicity the patients experience when they are exposed to Dacomitinib. Nearly 66% patients having some sort of diarrhea and requiring dose modification. And you can see the quality of life score and the patient related outcomes. Looks that it is better as far as cough, dyspnea, pain, the pain score with the chest pain or shoulder pain or fatigue are concerned. Yes, definitely Dacomitinib does better than Geftinib. We can look into the fatigue part, and so where Geftinib is better as far as the quality of life is concerned. If you look into the diarrhea part, yes, Dacomitinib is a little more toxic, and sore mouth again it is more toxic, and global quality of life. If you look into, there is less worsening of quality of life with Dacomitinib when compared to Geftinib. So from this, we have understood that Dacomitinib has better efficacy in terms of progression-free survival of nearly 14 months when compared to Geftinib, and with a little more toxicity in the form of greater diarrhea and even grade 3 diarrhea, and nearly 60-65% patients requiring some sort of dose modification, and patient-reported outcomes better in the Dacomitinib arm and compared to the Geftinib arm, especially in terms of cancer-related symptoms. So this is, and then coming on to the subgroup analysis. Uh, so first line Dacomitinib versus Geftinib in advanced NSCLC with EGFR mutation subgroups. So we had afatinib data where exon 19 was more favored by afatinib when compared to exon 21. So this was a subgroup analysis. As per the baseline stratification, they looked, is there any preferential activity of Dacomitinib on exon 19 or 21? And you can see, uh, so this was the baseline study design as I already showed you. And in the exon 19, they did, of course, better than the exon 21, 16 months of progression-free survival versus 9.2. Again, this is the investigator assessment, 16.6. And if it is exon 21, it comes down to 12.3 and 14.7. Yes, exon 19 did slightly better than the exon 21 subgroup, but the magnitude of difference or the magnitude of benefit was equal in both exon 19 and exon 21. You can see exon 19 deletion. You can see the number of responses, complete response in 5% with Dacomitinib. Whether it is exon 19 or exon 21, both had a equal magnitude of difference. However, the numerically exon 19 was superior because of its biology and the affinity of these TKIs to exon 19 inhibition. Again, this is uh, this is the waterfall plot where the response rates are better with the exon 19 and again exon 21. So the duration of response was also a little better, numerically better in the exon 19 when compared to exon 21. However, uh, uh, it was better than Geftinib in both exon 19 and 21. So it prolonged PFS versus Geftinib in both patient population. Objective response rates were comparable between Dacomitinib and Geftinib in both patient populations. Duration of response was significantly improved with Dacomitinib versus Gefitinib in both patient populations. So Dacomitinib did numerically have a better, if you compare 21 versus 19, yes, Dacomitinib had a numerically better exon 19 as a subgroup, but when you compare it to Gefitinib, it was efficacious in both exon 19 and exon 21. Objective response rates were not that different. Whereas if you look into the duration of response, yes, uh, 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 Dacomitinib was superior than Gefitinib in duration of response in both exon 19 and exon 21. So this is the conclusion. So Archer 1050 is the first randomized phase 3 trial to compare a second generation EGFR TKI with a standard first line TKI. Dacomitinib was superior to Gefitinib with respect to PFS and duration of response. You can see the PFS of 14.7 versus 9.2, the duration of response being 14.8 versus 8.3 months, and the overall response rate was similar for both Dacomitinib and Gefitinib treated patients. PFS and ORR with Dacomitinib compared to Gefitinib were similar in both exon 19 and exon 21. So we had Afatinib where the comparison was the chemo arm and was not the TKI. So this is the first ever second generation TKI being compared head to head with another TKI, in this occasion Gefitinib. So these were the conclusions as far as toxicity is concerned. So there were adverse events reported with Dacomitinib, and then there were no new safety signals were identified. Incidence of diarrhea, rash, and mucositis were higher with Dacomitinib. Incidence of hepatic toxicity was higher with Gefitinib, and dose modification is more frequent with Dacomitinib. Patients treated with Dacomitinib shared greater overall improvements in patient-reported measures of key disease-associated symptoms compared to a Gefitinib group. Dacomitinib should be considered as a new treatment option for first-line management of EGFR mutated NSCLC. So, if you look into the patient-reported outcomes, those symptoms that are due to disease improved significantly with Dacomitinib when compared to Gefitinib. Whereas, if you look into the patient-reported outcomes for mucositis and diarrhea, there Gefitinib did better than Dacomitinib. Then the safety and efficacy of Dacomitinib in the subgroup of Asian patients, and you can look into the Asian patients. Nearly 70% were Asian patients, and you can see the numbers 227 and 225. So these were the baseline characteristics. They were well balanced. You can see again exon 19 and 21. And you can see the statistically significant difference in PFS of 16.5 versus 9.3. And what is staggering is the statistically significant overall survival difference with a hazard ratio of 0.75. 37.7 months overall survival in the Asian subset when compared to 29 months in the Gefitinib subset. So Dacomitinib did have a 37 months overall survival when compared to 29 months as so there was a statistically significant meaningful overall survival in the Asian subset and not in the overall population. So the intent to treat, you can see the objective response, complete response, partial response, stable disease, progressive disease, all the median duration of response in Asian was longer with Dacomitinib when compared to Gefitinib. So this was the adverse event profile. You can see again here when Asians did have significant diarrhea, nail changes, rash, stomatitis. These were quite frequent. And this was the dose reductions that was required. Nearly 67% patients required dose reduction in the Asian population also. So first line Dacomitinib was associated with significant prolongation of PFS and overall survival compared with Gefitinib in Asian patients with EGFR mutated advanced non-small cell lung cancer. Dacomitinib also demonstrated longer duration of response. The adverse event profiles of Dacomitinib and Gefitinib in Asian patients were consistent with that of the in the overall treated population. So the Asian patients did not have a greater side effect when compared to the overall population. Then this is the updated overall survival data we have from the Archer 1050. Again, at two in 2019, they had a cutoff. It was the same trial, same randomization, and you can see the overall survival. It was not that significant. You can see the hazard ratio of 0.76 overall survival, and then the moment you came to overall survival by 2019, it was nearly 41 months versus 33.6 months. It was statistically significant. So as the time goes, the curves have started to separate, and a select subgroup of patients on Dacomitinib continue to respond and survive when compared to Geftinib, where they progress. You can see the the, the red line goes down once you cross 2 years. So that means that Geftinib's responses and survival is short-living when compared to Dacomitinib. So as you expose the drug for a longer duration of time, the efficacy becomes better and better. And those patients who are on Dacomitinib for a longer time, they tend to have a greater PFS and even a statistically significant overall survival. So these are the subgroup of patients: Asians, non-Asians, overall survival plot in favor of Dacomitinib. And if you look into the exon 21 subgroup, you can see that Dacomitinib does significantly better when compared to Geftinib. And even in the exon 19 subgroup, you can see the p-value of 0.02 in the exon 21 subgroup with a hazard ratio of 0.66. So basically, exon 21 is a little bit difficult to treat population when compared to exon 19. So therefore, giving a stronger and a better treatment does matter in the exon 21 subgroup when compared to exon 19. So this is the Asian population overall survival. You can see the overall survival at 42 months is nearly 45 versus 36.8. 45% versus 36.8% at 42, which was statistically significant. With extended follow-up of 47.9 months, the updated analysis confirmed previous results, demonstrating improvement of overall survival of Geftinib when compared to overall survival when compared to Geftinib. Improvement of overall survival was notable in Asian population. Improvement in overall survival was observed in exon 19 and also in exon 21. The benefit of OS from Dacomitinib treatment was maintained in patients, even those who had dose reduction. Okay, so this is the dosing recommendations. Recommended dose is 45 milligrams taken orally once a day until progression or unacceptable toxicities. Dose modification may be based on is required based on the individual safety and tolerability. You can see it is available in tablet in the form of all the three: 45, 30 and 15 milligram. And you can see the first dose reduction as to 30 milligram and second dose reduction as 15 milligram. And nearly 60% or 65% patients required dose reduction in the clinical trial. It can be taken with or without food. If a patient vomits or misses a dose, an additional dose should not be taken, and the next prescribed dose should be taken at the usual time in the next day. We should avoid concomitant use of proton pump inhibitors. If at all required, we can use H2 blockers. And we need to administer Dacomitinib at least 6 hours before or 10 hours after taking a H2 blocker. These are quite important when we counsel our patients for Dacomitinib. So with this, I would conclude saying my final remarks that Dacomitinib is the first second generation TKI where we had data of head-to-head comparison of a second generation TKI with the first generation TKI. So you did have the Archer 1050 was a randomized study where there was a statistically significant improvement in progression-free survival crossing 1 year, nearly 14 months. And then when you came on to the Asian population, we have an overall survival benefit. It was efficacious both in exon 19 and also in exon 21. However, exon 21 looks more promising. And if looking at the toxicity data, yes, diarrhea, mucositis are a matter of concern. However, with proper supportive measures and dose reductions whenever required, uh, um, we can manage the toxicities. And you can see the efficacy of Dacomitinib continues and becomes better as the time goes on when compared to uh, Jeftinib. And even after dose reduction, the efficacy of Dacomitinib is not lost. So, with this, the take home message is Dacomitinib is definitely a preferred TKI for the first line management of non small cell lung cancer with a activating EGFR mutation. So, I would thank Pfizer to give me the opportunity. I would be happy to take up any questions, or else we can conclude the session. Over to you, Dr. Mohit.